Today I will be discussing laboratory equipment care and maintenance, and I have chosen to do the microscope. So as you can see, it's important when it's not in use to keep it covered. So in order to clean the microscope, you definitely want to make sure you completely wipe it down after every use. You can use, to clean the lens, you can use either methanol if needed or specially formulated lens cleaner. If when you're using the oil for the immersion lens, if there's excess oil on the lens, you can use xylene. So we have our wipes here, and you want to wipe the eyepiece, the stage, move this around so you can make sure you get all the dust off. Carefully clean the lens. And then you can check to make sure if there's any debris in the eyepiece. You can turn it on and move each eyepiece separately, and if any debris moves, you know that it's inside and you have to clean that off. You wipe down every magnification lens, especially the oil immersion lens. It's very important to make sure all excess oil is off. Professional maintenance needs to be done annually. If any other issues arise, you can do that sooner. It is also important to note to make sure you have your microscope in an area where it isn't going to be moved or jarred or shaken, because that can definitely damage this equipment, and to make sure it's someplace where fluids aren't going to be splashing, it's not going to get super dirty. So we have it here in this corner. I'm going to go ahead and put the cover back on since we're not using it. So today I'll be performing an ELISA test. ELISA test can test for numerous things. What I'm going to be doing today is the feline pancreatic lipase test. The test has been sitting out for the allotted 30 minutes to get up to room temperature. And I have all the instructions out here. This does determine if the serum sample has the pancreatic lipase levels in the feline serum. So this is a feline sample. And what I'm going to do, first I'll open the test, and I have my conjugate sitting out here as well. It has a pipette, so I'm going to do 3 drops of the sample into the test well, or actually, no, into this. Okay. And now 4 drops of the conjugate. And then once this is mixed, I will be able to put it into the test. You gently invert it. And then I have my test right here. I'm going to be putting the conjugate and serum mixture together into this little test well. Make sure all of it goes. And then what you do is, as it's absorbed and once it starts going into this tiny window at the bottom of the test, then you snap it down. And let's see, you need to wait 10 minutes and then you can read the test. It's almost there. And as you can see, there's some blue in there, so now I'm going to go ahead and snap it down and then wait the 10 minutes. So the 10 minutes have passed and we have the results of the test. How to interpret them is if the 2 colored dots are the same color, or if the one on the right is darker, it's abnormal. If the 2 colored dots, the one on the left is darker, it's normal, and if only a color comes up on the left side, it's also normal. What we have here is you can clearly see that this right dot is definitely darker than the left dot, so that means that this is an abnormal test. So today I'll be demonstrating how to perform a modified Knott's test. This is used to concentrate and then identify any microfilaria that might be in the patient, specifically the heartworm, Diafilaria amitis. So what I have some formula, and so I'm going to take 9 mLs of that into my centrifuge tube. And then I'm going to mix that with an ml of blood that's not clotted and it's an EDTA. And then I'm going to gently mix, and then I'm going to go ahead and centrifuge this at 1500 RPMs for 5 minutes. So now that it's been centrifuged, you can see there's a pellet at the bottom, and I'm going to discard the super net without disturbing that. So now what I'm going to do is mix 1 drop of new methylene blue, and then I'm going to use my pipette and mix the stain with the pellet. And now I have my slide and a cover slip. I'm going to add a drop of this to my slide. And then I will add my cover slip, and then we will examine this under the microscope. So now that my slide is ready, I'm going to go ahead and look at it under the microscope. I want to make sure to start on the lowest setting first, and then I can go ahead and focus more. And you'll also want to differentiate this microfilaria from the non-pathogenic microfilaria. Okay. Let's see. So I'm just going to make my way across the slide, checking to make sure I don't see any microfilaria. And I am not seeing anything. So another test you can do is a direct smear, and that'll just double check that we do not see any microfilaria in this patient sample. Today I'll be performing a fecal flotation test. So I have my fecal flotation solution in here, and then I'm going to mix a couple grams of feces with the solution. And then what we're going to do is take a piece of gauze and strain the solution into the test that's being into the test tube that's being used. So I'm going to go over to the sink and do that. And now once I have finished straining, you see that I have the meniscus over the top of the tube. I'm going to take my cover slip and set that on top, and then you let that sit for 10 to 15 minutes. Once that's done, you carefully remove the cover slip, and you will put it on a slide like so. And then you can look under the microscope and see if there's any eggs or parasites in the feces. Today I'll be performing a fecal test. It's the fecal centrifugation. So what we have, I have some fecal solution in a cup, and then I'm going to take a couple grams of feces. You want to go ahead and mix this thoroughly. And then what we're going to do is strain this over this test tube to be centrifuged. We'll strain the solution over here. And then after this is fully strained, you want to leave a little bit of room at the top, and then we're going to centrifuge this for 5 minutes. Now that my sample has been centrifuged for 5 minutes, I'm going to go ahead and fill it the rest of the way up. Until the meniscus forms. And then I'm going to place a cover slip over that and allow that to sit for 10 to 15 minutes, and then you carefully remove the cover slip and place it on a slide, and then you can look at it under the microscope. Today I'll be demonstrating how to perform a fecal test, the direct smear technique. So what you do is you take a couple grams of feces, you'll put that on the slide, and then you'll also mix that with some saline or fecal sedimentation solution. And you want to kind of smear it together. I'm going to get rid of this bigger chunk till it's homogeneous. And then we'll smear it across the slide so that it's thin enough to read. You can see it's a very thin amount on there. And then you'll place a cover slip, and then this is ready to be read under the microscope. Today I will be demonstrating a fecal test sedimentation. So I have some tap water in a cup, and I'm going to use a tongue depressor to mix a couple grams of feces with the water. Then I will go ahead and again strain the sample into the test tube being used. Come over to the sink to do that. Okay, now that it's fully strained into the test tube, I'm going to go ahead and centrifuge it for 5 minutes. Now that my sample has been centrifuged, I'm going to go ahead and pour off the top layer without disturbing the pellet. Now I'm going to pipette off a couple drops and place it onto a microscope slide. Now you can add on iodine, but that's optional. And now what we're going to do is place a cover slip over the slide, and then we can go ahead and go over to the microscope and check for any parasites. Today I'll be performing how to do a free catch urine sample, or otherwise known as avoided sample. This is one of 3 ways you can catch a urine sample. This isn't necessarily sterile, so if you're looking to do a cytology or culture, it's better to do a catheterization or a cystocentesis. The best time to catch the urine sample is in the morning when it's most concentrated and it's less likely to be affected by any dietary factors. When you do catch the urine sample, you want to catch it midstream because it's less likely to be contaminated by the outer urinary tract. So today I'll be participating in a cystocentesis. There are a couple different ways to get a cysto. You can do a blind stick. You can also do by palpation. We're going to be doing ultrasound guided. You would do a cystocentesis if you're looking to get a urine sample for a culture and sensitivity. You can also do a catheterization for that as well if a cysto is not available. So I have the probe isolated on the bladder, and then my coworker here will take her needle attached to her syringe, and once she's in the bladder, she'll gently aspirate the urine out, and she just sprayed over the bladder with some alcohol to sanitize the area. And then we can put this in the appropriate tube or the culturette. Demonstrating how to put in a urinary catheter. I will go ahead and start by scrubbing the area. Good job. Okay. And next I will go ahead and take sterile syringe and flush the prepuce with a chlorhexidine solution. Okay. So now I'm going to measure, and this will kind of help us estimate how much of the catheter we need to put in. And then putting it around, it looks like we'll probably need to insert most of the length to get into the bladder. Put on sterile gloves. And next, I will go ahead and get the catheter out. I'm going to be using a red rubber. There are a couple different catheters you can use for different situations. A polypropylene catheter would work well in this situation. It's more of a rigid catheter when you're just trying to obtain a urine sample or to empty the bladder. A Foley catheter would be better if you plan on keeping the catheter indwelling in the patient. It's a little more flexible and more comfortable for them, and there's also a distal cuff that you can inject sterile water or sterile saline into to help it stay in the bladder. But today I'll be using a red rubber. Now I have the catheter, and then we'll need to use sterile lube for this. Now go ahead and lubricate the tip of the sterile catheter with the lube.
Good boy, buddy.
Good boy. And then you'll just slowly insert through the penis. And you want to make sure you're not pushing too hard.
Good job.
Good boy.
Good job, buddy.
And then you can see that we are getting some urine out. And then when we do hook up, you want to make sure that you discard the first couple milliliters of the urine sample because you want the most sterile sample you can get. And this procedure can be done for a culture and sensitivity when a cysto is not available to do. Okay. All right, and then we have some urine in the syringe, and then I'm going to go ahead and just slowly take the catheter out.
Good boy.
Good job.
Good job,
Okay.
buddy.
Today I'll be performing how to obtain and diagnose an ear swab cytology. When we usually do the cytologies, the patient comes in with either red swollen ears, they're scratching a lot, there's a funky odor like yeasty, you can see extra discharge, they're shaking their head excessively. Those are some of the main symptoms. And then once you look in with an otoscope, you can see any extra debris, wax in the inner part of the ear. When collecting the sample, it's important to know that the patient's ear canal is different than ours. It's shaped like an L, so the eardrum and everything important is over here. And when we go in to take the sample, we don't have to worry about hitting this like we do with our ears. So I'm going to take a Q-tip, and then you can just go right in. And then you can see that I do have some stuff on the end of my Q-tip. If you're going to do both ears, I think that it's important to use 2 different Q-tips, and then when you make the slide, you can either do 2 different slides, or you can do one part this ear and the other part the other ear, and just make sure to remember. So now to make the slide, I have my sample, I have a slide, and what you want to do is roll it on there. You don't want to push too hard, but you want to make sure that you get enough of that sample on there. I'm just going to keep going. You can see. Do a little more. And since I only took one sample from his right ear, I don't have to worry about keeping one side on over here and the other ear on this side. So now that I have that, one of the important things to do is to heat fix the sample. If there's excessive wax on there, that can kind of affect your ability to read the sample properly once it's stained under the microscope. So heat fixing can melt and dissolve some of the extra wax that can be on the slide. It's important not to overheat it because that can destroy any of the cellular components of the slide. So I have just a little lighter here. You can use a hair dryer. There's multiple different ways to do this. But I'm just gonna slowly do that a couple times. Okay. And now I have a clip, and I have my staining station kind of set up here. We use the Div Quick stain, so we first start with the blue, red, and then purple, and we set it in here for 10 seconds, and then we'll move on to each separate one. The staining procedure is definitely very important to make sure all the components are correctly stained so we can read them. If we don't do the procedure properly, we could come up with a false negative, a false positive, and treat the patient with something it doesn't necessarily need, or miss something, and not give the patient what they actually need. There's also different ways to read an ear cytology slide. If you're looking for ear mites, you don't need to do the staining procedure. You only need to put the sample on the slide and do mineral oil instead, and then look, because sometimes they're still alive and moving and you can see them directly. You don't need to stain it and go through each magnification like that. With this one, we're staining, and then we're going to be using the immersion oil, and then we'll go from each magnification and focus until we get to the immersion oil lens, because then that's when we make our diagnostics or diagnosis. Okay, so now what I'm going to do is rinse the back of the slide lightly, which is very important to make sure I don't rinse off any of the sample I need. And then we have our bibulous paper, and I'll just go ahead and set this in here to help kind of dry off, get any of that excess water off. You don't need to get all the water completely off. Sometimes I think it's easier if you get all the water off, but it's not actually necessary. And then I'm going to take a Kim wipe and just wipe the bottom of that to get anything else off. And then you can see my slide. And now what I'm going to do is go ahead and put this on the microscope, turn it on, and then I'm going to go through each magnification and focus. Okay, I'm going to keep moving through. It's definitely important to make sure you focus through each magnification and make sure you're not missing anything. Sometimes I find that if you skip to the highest magnification, you can kind of lose the sample and it's hard to find it again, and then you have to start over. So now I'm on the 40 magnification. Okay. Go. A good spot. And now I'm going to be doing the oil immersion lens. And what I'll do, just take a pipette, and I just need 1 drop of it directly on the slide. And place that lens over it, and now I can make my diagnosis. And right now, all I'm really seeing is some debris, nothing. I don't see any yeast buds. How to obtain a skin scraping sample. My blade has already been dulled. I have a 10 blade with me. I have a slide ready to be used, and I have my mineral oil. So where you want to get the sample from is where you see any obvious lesions or infection. What you want to do is gently scrape on the skin back and forth. You do also want to get some capillary blood if you're suspecting Demodex or scabies, because that does live under the skin. For calateella or walking dandruff, that would be above the skin. For sarcoptes, we don't really see that very often, but you would want to get capillary blood for that because that can be below the surface. So then what I'll do is pinch the skin, and then, like I said, scrape back and forth. And then you want to do it until you see some capillary blood, and you want to dull the blade before so you don't make an incision. Okay. And then once I have a good enough sample, I'll go ahead, put some mineral oil on my slide, and then you just want to wipe it in and make sure you get all the cells on there. And then what I'll do is go ahead and look at it under the microscope, and then we can make our diagnosis there. So now that I have my slide prepared for the skin scraping, I'm going to go ahead and use the microscope to look for any infection, parasites. And what you'll do is focus on 4, and then you'll read the slide on 10. So now I'm focusing on 4. Now I'm going to go up to the 10 and see if I can find anything. So far I'm not seeing anything. I'm just seeing some of the cells I scraped up, but it looks like that our skin scraping is negative. How to obtain a dermatified test, a fungal test sample. There's a couple different ways you can get them. I'm going to be using sterile hemostats. You can also use a toothbrush. So what you'll want to do is obtain the sample from any area that you're suspicious of. And you want to make sure that you pluck the hairs and you get the full follicle. So I'll go ahead and just pluck some, so I have a good amount there. And then I'm going to be using a DTM medium in the tube format. So I'll go ahead and twist this off. And then you place the hairs onto the medium. And this will incubate for multiple days. You'll want to make sure that the lid is not screwed on fully tight. This needs to be kept in a dry area, and then you'll observe it every day for any color change or growth. So now that this is incubated for the allotted period of time, I'm going to go ahead and fix it onto the slide so I can check under a microscope to make sure that our diagnosis is correct. Any red or teal color change on the medium is not alone diagnostic enough to have a positive result. So I have my slide here. I'm going to go ahead and put a drop of the blue stain. Go ahead and use a hemostat to get the tape into the test tube. And then I'll go ahead and pat down, making sure I'm not breaking the medium, just getting any evidence of that onto my tape. And I'll go ahead and place that onto my slide. I'll go ahead and put a cover slip on top and read it under the microscope. Okay. So there wasn't any color change on the medium, but again, that doesn't necessarily mean that it is negative. So I'm just going to make my way through the slide. I'm not seeing anything so far. Just some debris and some of the hair. Okay, so this sample also looks negative, which is great news. Assisting in a necropsy with Dr. Reeds. We have our supplies out. I have a pair of scissors, a 15 blade on the blade holder, and some hemostats, along with some biopsy jars that we'll be putting tissue samples in. Since I could not get an owner-approved necropsy, I purchased a feed rat that has been thawed, which we'll be performing the necropsy on today. And to start with, Dr. Reeds will go ahead and do a preliminary external exam.
First, you just look for any external abnormalities or wounds. If there's some blood in his mouth.
And we also each have on protective gear. We have a gown, gloves, and a mask on.
So nothing Feels obviously broken, but other than right now you can just see there's blood in this mouth.
And now she'll go ahead and make her midline incision. And when performing a necropsy, we're looking for any obvious parasites in the intestinal tract. There's a couple different ways that you can extract those. She'll just be looking at the tissues and handing me samples to send out for evaluation.
Well, just on first look, there's a lot of bruising, red dark color change to the body wall, which may or may either be suited with death or if the brat was dispatched physically versus with medication. Obviously, it wasn't because it's a feeder, but we'll see some of this bruising that you see. Liver's normal in size. Stomach is empty. Spleen is normal. Intestines are a little congested, which again could just be post-mortem change. Looking into the chest cavity, there's a lot of congestion in the lungs and the heart. So for sample, go ahead and take a piece of the lung.
And these are already labeled with the date and hospital name, but I will go ahead and also add where each tissue is coming from. Today I will be discussing rabies suspect sample handling. Technicians that have been pre-immunized to rabies and have a serum titer of 1 to 5 are the only ones allowed to handle the sampling. For when handling the sample, you want to make sure you have the correct protective gear on, which is different for smaller animals and larger animals. For smaller animals, you need to be double gloved, have a protective mask on, and goggles. For larger animals that are larger than large dogs, you need to be wearing rubber boots, a scrub suit, an apron, a protective face shield, and then double gloved as well. But with the double gloved, you want a heavy vinyl as your outer glove. That includes gauntlets. In regards to which specimen you need to send in, only the head is required to be submitted, and that is disconnected by disarticulation at the atlanto-occipital junction using either a disposable knife or scalpel. When you have the sample ready to submit, the sample needs to be double bagged and clearly marked as a rabies suspect sample. In Maryland, you need to make sure that the sample is in a cooler as identified as only a rabies cooler, with ice packs, no dry ice, and you do not want to submit anything frozen because that can delay testing. Also, if any other samples are in the rabies cooler that are not rabies suspect, they will not accept the rabies sample. What needs to be accompanied with that is the correct form that's completely and correctly filled out with the exposure date. Those containers also need to be fully closable and waterproof. When filling the cooler with ice packs, you want to make sure that the ice packs don't take up more than a third of the cooler. For the rest of the carcass of the animal, you need to make sure it's double bagged in a red biohazard bag, labeled as rabies suspect, and disposed of as hazardous biological waste. Today I'll be performing a vaginal cytology swab. The first thing we need to do is scrub the vulva area with chlorhexidine, and I have a chlorhexidine scrub. And then I have my sterile swab out, and I've already drawn up some sterile saline into a syringe to moisten the swab. And the important thing is you want to insert the swab at an almost vertical angle, and then a couple inches into the vagina, you come up parallel to the floor. It's okay, boo. And then I'll roll back and forth to get an adequate amount of cells.
Good girl.
And then I'll come out. I'm going to prepare the slide, and what we'll do is just roll the swab over the slide to make sure we get all the cells onto here. And then I'll go ahead and let my slide dry, and then we'll stain and look under the microscope. So now that my slide has properly dried, I'm going to go ahead and stain it. And I have my stain set up all here. I'm going to do it for 10 seconds in each stain. And then what I'll do once it's finished staining, I'll rinse the back off, and then we can look under the microscope and see what cells we find, and that'll help us determine which stage of estrus the patient is in. So you see that I got a good amount of sample on here. And I'll start on the lowest magnification and then work my way up. So what I'm seeing a lot right now of is some non-cornified epithelial cells. I'm also going to look around to see if I see any neutrophils. Oh, I do see some neutrophils. I'll just keep going through. Make sure I do a good read of this slide. I'm not seeing any bacteria. Okay, so from the looks of it, our patient is to be an anestrus. The 4 stages of estrus are anestrus, proestrus, estrus, and metaestrus. In anestrus, the bitch is not receptive to any male dogs. There's no vulvular swelling, no indications that she's going into heat. When you look microscopically, you'll mostly see non-cornified squamous epithelial cells. You may also see some neutrophils, but no erythrocytes. A bitch in proestrus does have vulvular swelling with a reddish discharge. She is attracting male dogs, but not accepting them. In early proestrus, you see a high number of erythrocytes. As proestrus continues, you'll see a gradual decrease, and then there's also basal and parabasal epithelial cells present. A bitch in estrus has a history of a recent proestrus. She has vulvular swelling. The discharge is now more a pinkish or straw colored. She is attracting males and she is accepting them that are attempting to mate. If you look at a vaginal smear under the microscope, you will see that most of the epithelial cells are now cornified and anuclear. There are no neutrophils present, but you may see some erythrocytes. In later proestrus, you'll see that most of the epithelial cells are beginning to cornify, and then you will also see a small number of neutrophils. With estrus, erythrocyte numbers are still decreasing, but the neutrophil numbers are increasing rapidly. In met-estrus, the bitch has had a recent estrus and there is no longer any vulvular swelling or any discharge. She no longer attracts any males and is not receptive to any. With the cornified squamous epithelial cells, they are now replaced by non-cornified epithelial cells, and there's going to be a lot of cytologic debris on the slide if you look at it microscopically. So today I will be demonstrating how to manually cross-match for a blood transfusion. I have both of my donor and recipient serum labeled. That's already been spun down. And then I have the recipient and the donor anticoagulated blood in purple top, so I'm going to go ahead and centrifuge these down now. Now that the tubes with the anticoagulated blood in them have been spun down, we're going to go ahead and take out the plasma that's sitting on top, and with the remaining blood in the EDTA tube, we're going to rinse the erythrocytes by placing 1 to 2 drops in a new tube with no additive in it, and then fill the rest of it up with a saline solution. Then you want to be careful with these not to remix since the blood has not been clotted. Okay. This is the recipient. This is the donor. And being careful not to touch the erythrocytes at the bottom of the tube. Okay, so now we get a new pipette. We're going to place 1 to 2 drops of the spun down cells into these new tubes. 1, 2. And now we're going to be doing the wash. And once this is filled with the saline, I'm going to spin this down again for 1 minute, and it's going to be at 3,400 RPMs. Just a little bit more than that one. Do the same thing for the other tube. And the important thing to remember is to make sure you label all of your tubes, because it's very important not to mix up the samples. Okay, now we'll go ahead and centrifuge these. So after the first rinse, I've spun them down, and as you can see, all the erythrocytes are down there. What I'm going to do now is take off the supernat, and then we're going to wash again like we did, fill the rest of the tube up with saline, and do this for another 2 times. So after you've performed the final wash, you should have the supernat is clear and colorless, as you can see, and that means that the erythrocytes have been completely washed. So now what we're going to do is make a 2% erythrocyte suspension solution. Take 0.02 and place it into the new tube. Recipient. And now I'm going to do 0.98 of saline. Do a major and minor cross match. So I have my 2 new tubes, minor and major, labeled, and I'm going to take two drops of my donor will go in my minor, 2 drops of the donor serum, and then 2 drops of the recipient's cell suspension. We'll go ahead and mix that gently. Now we're going to do the major, and that's going to take 2 drops of the recipient serum. And then 2 drops. So for the major cross match, we are going to take we have 2 drops of the recipient serum in here, and then we're going to take 2 drops of the donor suspension and mix that in. And now, to check for any anticoagulation, we're going to make a control tube. So, I'm just going to label these control donor and control recipient. So for this, we're going to mix each of the respective serum and cell suspension in here for the same patient. So we'll take, this is the donor, 2 drops of this, and 2 drops So I have the control donor, and now I need the control recipient. Two drops of this serum, and then 2 drops of the cell suspension. So now I have both of my controls. Now that I have all of my sample tubes set up for the control and then each major and minor cross match, I need to gently mix them, and then they're going to incubate at room temperature for 30 minutes. Now that all of my samples have been sitting out at room temperature for 30 minutes, I just finished centrifuging them. So what we want to do is look at them visually and see if we see any agglutination hemolysis. You should not see any hemolysis in your control samples. If you do, there's probably a contaminant, and then you can't make a correct decision whether this is a good match for a transfusion. So I don't see any in my controls, which is good. You can also kind of flick the bottom. I do see some hemolysis in my major, but I don't see any hemolysis in my minor. So now what I can do is to check microscopically, that was macroscopically, and I'm going to go ahead and get some slides and place a drop of each on a slide and then look at it under the microscope. So now what I'm going to do is take a drop of each sample and place it on a microscope slide so I can check under the microscope to see if there's any agglutination. You want to start off with the lowest power. And then lower and then change your condenser so there's more contrast. So with the major, I already knew that I saw some hemolysis macroscopically, and I do see some microscopically as well. So now I'll clean off my microscope. And I'll go ahead and take a look at the minor. So now that I've looked at both of my samples under the microscope and visually, I can say that there was hemolysis and agglutination in the major cross-match, which means that they are not an adequate recipient and donor for each other for a transfusion. Slight hemolysis in canines is non-specific, but if you see significant hemolysis and agglutination, that means that they are not a good match for a transfusion.